Hello and welcome. I am about to launch a poll to see if you have joined us before. You can fill it out if you would like to. Otherwise, you don't have to. You can also drop into the chat where you're calling in from today. And as we wait for people to kind of filter in, I'd like to introduce myself. My name is Madison Burnett, and I'm a BCBA. I lead our professional development program, and I'll be available to support during today's webinar. In addition to that role, I work alongside other BCBAs on our clinician-led recruitment team, and I support in the effort in recruiting quality professionals to join our team. If you are interested in joining MPG, please indicate so in the post-webinar survey at the end of this webinar, or you can email careers@manhattanpsychologygroup.com. Before we begin, I'd like to tell you a little bit about Manhattan Psychology Group. Ashley, if you could click onto the next slide, that'd be great. We were established in 2011, and we've continued to grow our team consisting of skilled adult and child psychologists, neuropsychologists, behavior analysts, special educators, licensed social workers, and behavior interventionists. As a team, we're committed to wraparound care, which includes our wide range of services from mental health and testing to ABA and educational services. This holistic approach allows us to address various needs and challenges with compassion and care. We provide services to clients at our Upper West Side and Long Island City offices, in home, school, and clinic-based settings, as well as through telehealth. Our team is committed to serving individuals, couples, and families of all ages and diverse settings. We are pleased to offer these free monthly webinars for parents and professionals where we'll continue to learn and foster meaningful connections. Our vision at MPG is to create a future where individuals and their families feel supported, connected, and empowered. Our mission is to provide a multidisciplinary, integrated support for individuals and their families who experience mental health, behavioral, and educational challenges. In an effort to stand by our mission and vision, we are thrilled to offer these free 20-minute phone consultations with our clinical team. You can schedule a time by visiting our website at www.manhattanpsychologygroup.com, or you can follow the link that I'll be putting in the chat momentarily. All right, now for some housekeeping information. This webinar is not eligible for continuing education. We will be leaving the chat open, but please post any questions you might have in the Q&A so we can make sure that they're seen. If there's time at the end of the presentation, Ashley will answer some of these questions. And now I'm excited to introduce today's speaker. Ashley Pennington received her Bachelor's of Science in Psychology and Master's of Arts in Clinical Adult Psychology from Southern Illinois University, Edwardsville. Ashley began her career as a direct care counselor at a residential treatment center in which she found a passion for guiding clients and families through the healing process. Ashley values the opportunity of being the first point of contact for all of the clients and their loved ones and continuing care providers, ensuring that all parties involved receive quality care before, during, and after the admission process. Within her decade of experience, Ashley has held positions within the leadership, such as Director of Admissions for the Startup Residential Treatment Center, Associate Vice President of the Business Development as a Residential Networks of Services, supporting a team of high-performing leaders, and most recently, the National Director of Clinical Partnerships supporting the full continuum of care for teens, young adults, and their families struggling with primary behavioral health challenges. Ashley has served as the president of the Eating Disorders Task Force of Indiana, marketing officer of the International Association of Eating Disorders Professional Heartland Chapter, and vice president of the City of Madison, Indiana Redevelopment Authority. Ashley has a passion for guiding clients and families to quality care and values the opportunity to build unconditional trust within the provider community. And now, without further ado, I'll hand it over to Ashley.
All right. Thank you so much, Madison. Well, welcome everyone. Thank you so much for joining us today. And thank you so much for that introduction, too. So, yeah, I'm Ashley Pennington. I'm our National Director of Clinical Partnerships for Embark Behavioral Health. Yeah, I've been in behavioral health care for about 15 years. So served in, like you heard, different capacities. I've worked the floor as frontline staff, admissions, utilization review, and most recently business development. But I will say my number one job is I'm a mom. So I'm going to come at you and come with you in this space as a fellow parent. So the way that I kind of just do my job is I come at it from that side of things as a mom, as a parent. So and this is going to be just a little bit informal. So if you have questions, please feel free to put them in the chat. I will give you my personal cell number as well. You will have that to be able to use if you need it at any time too. I just want to be here for support. So I'm going to talk a little bit about spinning our wheels when residential care becomes reality. So, a little bit about kind of what things are going to look like today. A couple things. So, from the presentation, you're going to figure out three things. So, one, discovering signs that your child may need a higher level of care. What does that higher level of care look like? What does it mean? The second thing is being able to gain an understanding of what does it look like when we are in a residential care setting, because there are so many different facilities. And so, what does the basic structure look like when you've been told your child needs residential care? And then the last thing is, I want to debunk some myths and misconceptions surrounding residential care, because I know there's a lot out there right now about, they're calling it the troubled youth industry. I don't like that phrase. I just think I just don't like it. But I want to definitely debunk some myths around that and kind of clear up some generalizations. So, these are the things that we're really going to talk about today. So, first up, you've just been told that your child needs residential care. What does that even mean? And where do you even start? And let me tell you, it is overwhelming, right? What does it mean? Where do you start? And a lot of times we go to Google. And I want to be the first to tell you that you have support through MPG. You also have support through me as well. I don't want you to go to Google. I get overwhelmed with Google, and I've been in the industry for as long as I have been, right? Things have changed, things have flipped, things have been added, things have been subtracted. You have a support system. So please don't overwhelm yourself with Google, because it will give you so much more information than you'll ever need. There's also, we know, algorithms and different things. So this is going to be so helpful for you, but know that you have support with MPG, you have support with me as well. So you've been told your child needs residential. Where do you start? So first off, we got to know levels of care, right? We got to know, what does each level of care mean? So I'm going to go through each level of care, but what I'm going to do is I'm going to go through it with a hypothetical client, with, maybe kind of your child, so that you can see what the stages of care look like, right? So we're going to first go through inpatient hospitalization to residential to partial care to IOP to outpatient. So my hypothetical client here is, let's say, a 15-year-old boy with suicide ideation, right? Threatening to kill himself. So you have a 15-year-old boy that's threatening to kill himself. And what we look at first up is that inpatient hospitalization. We're going to look at acute care because we need to keep them safe. Right at this very moment, we need to keep them safe. So inpatient hospitalization is exactly what it is inpatient hospital. You are going to typically go to an ER or a crisis center. This is a safety issue, right? If a child is suicidal or homicidal, they can't keep themselves safe or others safe, then we are going to need to go to a hospital setting. And so typically this is going to be about a 7 to 10 day stay if they get admitted. Sometimes it's 72 hours, but typically inpatient hospitalization is going to be in a hospital setting. They are going to have 24-hour care to keep them safe. Now, from that 7 to 10 days, typically in that threshold of time, you're going to meet with a care manager who says, hey, they can't go from inpatient back home, right? They weren't safe. We don't feel comfortable sending them back home. So we're going to recommend residential. And that's typically where I come in, right? I work with the hospitals. I work with the different care managers for them to say, hey, we need to step this person down from inpatient into residential. Now, residential is typically going to be a house setting. It's typically a home, single family home, a big home that is a business. And typically, I would say it just depends. So you could have 6 rooms, you could have 6 people, all the way up to, if it's a giant home, some of them have about 16 to 20 people in their facilities, depending upon how big the facility is. But it is a home-like setting, so it is not a hospital. Usually, it's a home setting. And for residential, it's usually about 90 days that they're in this setting. It's 24/7 care. They have individual therapy. They have group therapy. they have family therapy, but they also have some education as well, which we'll talk a little bit about that. So they want to keep them in their school type setting as well. So typically, that's going to be about 90 days insurance backed as well, which we'll talk a little bit about. So after that 90 days, so client has been in residential, they step down into a day treatment program, which is typically PHP, partial hospitalization, partial care, day treatment. And that is about 8 to 10 hours a day, 5 to 7 days a week, right? So they're staying at home at night. Residential is different, right? They're at the residential care center, they're staying overnight. They come home, they step down again, they come home and they have this day treatment where they're there 8 to 10 hours a day, 5 to 7 days a week, and they're at home at night. That typically happens for about 4 to 6 weeks, depending upon what they need. And then they'll step down again into intensive outpatient or IOP care. And that is 3 to 4 hours a day, 3 to 5 days a week. And again, we typically start at 5 days and then we titrate down to 3. Again, as you can see, there are soft landings. We typically don't go from inpatient home or inpatient to outpatient. We do it in levels because we want a soft landing for them. We can't go from 24/7 care back home. That's just too hard for everyone. And so we do it in levels. IOP is typically, that's going to be again, it's usually at night, so 3 to 7, or you can do it during the day, depending upon the facility. And then we step back down to outpatient. And at that same time, what's really great is, let's say you're seeing the clinicians at MPG, they have been notified and they know everything that's going on in each level of care. So when they do come back for outpatient, they know exactly what happened, which is great because then you can pick up right where you last left off. So those are the different levels of care. So for us to be able to kind of conceptualize what this looks like, you might hear inpatient, you might hear residential, you might hear day treatment, IOP treatment, outpatient care. Those are kind of the different levels of what we're talking about, from most restrictive to least restrictive. Now, I will say, as clinicians, we have a code of ethics. And our code of ethics is we are required to give the least restrictive level of care recommendation. That's our code of ethics. So if you get the recommendation from a clinician that residential is the recommended level of care, know that that's not because they're getting paid by Embark or because they're getting told you have to do this in order to meet some quota. It is because they take a code of ethics, and it's because that's what your child needs. So I know there's a lot of like animosity and things, and I know there's a lot of just really like, it's really hard to get that recommendation, but know that we do take a code of ethics. We are required to give you the least restrictive level of care, and if residential is that level of care, then we need to make sure we abide by that for overall safety precautions. So we've gone through the levels of care. So how do we decide, right? How do we decide from this code of ethics that your child needs a higher level of care, right? Because we can't just say, oh, we can't look at somebody, right? Mental health is so much different than physical health, right? Someone has a broken leg. So you're like, okay, let me take an x-ray. The leg's broken. Okay, I know to put a cast on it. Okay, this is how long you need it on. All of those things. Again, mental health we know is different. So these are the American Psychiatric Association guidelines, the APA guidelines that we use as practitioners to recommend when a child needs a higher level of care. First, we need a psychiatric diagnosis. Have to have a psychiatric diagnosis that requires a therapeutic intervention. So depression, anxiety, borderline personality disorder, post-traumatic stress disorder, adjustment disorder, selective mutism, whatever it might be, there has to be a diagnosis. Now, we can also look at the level of severity of that diagnosis. Major depression with psychotic features, bipolar disorder with or without psychotic features. Again, we look at the level of severity of that psychiatric diagnosis, but we look at, okay, is there a diagnosis present? How much is that diagnosis impacting their daily functioning, right? Are they depressed to the point where they can't get out of bed, where they're refusing school, where you as parents are trying to get them out of bed? You're trying to go to work. Mornings are chaotic anyways, but then you have a child that's here that's not being able to perform their daily functioning their ADLs, and you're just spinning your right, you're spinning your wheels. And so we got to see the level of functioning, the level of acuity. The next thing we look at, the biggest thing we look at is safety. Is the client a danger to themselves or others? Overarching, when I am working with a family, I typically ask the question, is your child safe? Have they said that they are a risk to themselves? Have they threatened to kill themselves? Have they threatened to kill you or others? Safety is a number one priority. If they cannot be safe in their home, they have to go to an acute care setting. 100%. That is typically what we typically do just to keep them safe, right? As parents, that's our number one goal. I'm here to keep you safe. Have they tried a lower level of care? Are they in outpatient? Have they tried day treatment? Would day treatment be helpful? If they're not safe at night, probably not, right? Because mom, dad, you have to sleep. You can't be sitting by their bedside all night, every night. You have to sleep too. You have jobs and lives that you have to continue to go with. So if they can't be contained at home, then you do need 24-hour supervision. And the medical stability. Are they medically stable? Are they taking their medications? Are their labs within normal limits? I think of this a lot of times when I was working specifically in eating disorders. I started out my career in eating disorders, where our labs within normal limits, was the weight, the client's weight within normal limits, where they had a healthy weight, where their heart level, their heart was functioning at a normal capacity. Again, we're looking at medical stability. Do they need to be in a hospital? Do they need to be in 24/7 care in order to thrive, in order to live? So these are just the basics that we look at. Again, we have APA guidelines that we go through and try to figure out, does this client need a higher level of care? And if they check the boxes, then absolutely. So these are the things that we look at when you get that residential recommendation. So what does it look like? Right. And so these are pictures specifically. So, like I said, I work at Embark Behavioral Health. We've been around for over 25 years, specializing in the care of preteens, teens, young adults, and their families. So, we treat ages 9 to 28. This particular facility is the closest facility to you. This is our all female facility in Whitehaven, Pennsylvania, just right outside the Poconos Mountains. And this houses 12 to 17-year-old females. Now, I give you these pictures because, again, I want to be able to conceptualize with you that these are home-like settings. Most residential programs are going to be home-like settings, different from a hospital. It's going to look like a house. It's going to be a house probably before it was residential, but it's going to look and feel like a home, like they're going home. So, what do we expect? First up, we're going to look at safety, right? As parents, we look at safety. Again, this is one of our bedrooms. As you can see, we typically, care centers are different based upon where they are and what they do. For us, we do not have any single rooms. For us, we have more of the typically 3 to 4 beds to a room, sometimes 2 beds to a room. But we like to keep a little bit of a community based because we know that mental health issues thrive in isolation. So we want to make sure we keep it in a group setting. But we look at it from a safety standpoint. We have a safe and supportive environment. We have 24/7 nursing and clinical support, 24 hours a day, 7 days a week, board certified medical and clinical support, period. That is what you're going to get at most residential care facilities because that's what we need, right? Crises don't happen during the day, they happen at night usually. And so we have to have trained professionals to be able to help. We have dedicated frontline staff with required continuing education. I'm just going to put all those out there. So I will tell you, as someone who started out my career on the front line, I have a master's degree in clinical psychology. I have the book, the education, but I also have the floor education as well. And I will tell you, one of the things that I very much valued as when I started out as a clinician was the continuing education I got as a frontline staff member. Now, there are going to be a list of questions that I am going to give Madison to give to you, but if you want to write them down, if you're a note taker like me, one of the things that I like to ask that I think is so helpful as a parent when you're looking at residential care, depending upon the facility, is what kind of training do you give your frontline staff? right? What are their credentials? Do they have bachelor's degrees in psychology and social work? What's the continuing education? Do do hands-on support with them? Do you do virtual support with them? What do the different modules look like? Because the frontline staff are going to spend the most time with your child. They are going to take them to meals. They're going to sit with them at meals. They're going to sit with them in groups. They're going to sit with them in individual therapy. They're going to be with them when they have a meltdown, right? That floor staff, that frontline staff is going to be with them when the crisis happens. And so I always think about it when I was a frontline staff member, the type of training that I got in that moment. To be able to help avert the crisis, to be able to help diffuse the situation. So I always ask the question, what kind of training do your frontline staff get? They also have structured daily schedules. So again, we have clients that, as parents, we've tried to have a structured daily schedule and it's not working, right? Because your parents, because your mom, your dad, your parents, that's what you do. For us, we have structured daily schedules. They know exactly what they're doing. They're going to groups, they're going to individual therapy, they're going to experiential therapies, they're going to school. We'll talk a little bit more about school because I know that's so huge. We want to keep them in school when they're with us. But they have a structured daily schedule. They're busy all day, every day. They're working on themselves. They're getting to the core of what's going on inside. And so they're busy all day, every day. They're not laying in bed. They're not laying on the couch. They are 100% engaged because we want to get to the core issue of what's going on. And then the additional piece of it is national accreditation. One of the things that I think is so critical, especially now, is a lot of the things that's being uncovered in the youth mental health care industry is this accreditation. One of the questions that I think is so key for you to ask is, what is your accreditation? And a lot of facilities like ours is going to be Joint Commission accreditation. There's also CARF accreditation. You might see that CARF. Those are nationally recognized mental health accreditations to be able to say what we're doing is providing safe, good, great quality care for our clients. And we get surveyed to make sure we are providing quality care for clients. I would even go a step further to say, did you pass your last survey? Because if they didn't, then this is not going to be the best place for your child, right? From a safety standpoint. So again, I will provide those questions, but I think it's so key. If the more you know to be able to ask in that initial phone call, the more equipped you're going to be to feel like you're getting the best recommendation possible. So a lot of times I'll ask, what's your accreditation and did you pass your last survey? Okay, so that's the safety point of things. That's kind of the primary point I would say as a parent. The next piece we're going to look at is clinical. I'm going to just pull all of these up so you can see all of them at once. There we go. So clinical. So we looked at things from a safety standpoint. This is at our Whitehaven, Pennsylvania location. This is one of our therapeutic rooms. We do family therapy, individual therapy in there. I will say from a clinical standpoint, 24 hours a day, 7 days a week, board certified clinical and medical support. Again, if you're looking at residential centers, look at the staff page. That'll give you a good idea of the level of education, the level of experience that you can get at those centers. Licensed master's level and doctorate level staff as well. Again, look at that staff page when you're looking at residential centers. Make sure they're licensed providers. We're also utilizing evidence-based therapeutic modalities. So you might be familiar with dialectical behavioral therapy, DBT, cognitive behavioral therapy, trauma-focused. We use trauma-focused CBT, acceptance and commitment therapy. You might have heard of experiential therapies as well. You might have heard of polyvagal theory, all of those different things. I would ask, tell me about your therapeutic interventions, and see, if you're savvy, um, figure out, okay, what is my child going to be doing while they're there, right? Because we really want to know, hey, are they going to be getting the help that they need? I would also ask about outcomes. Is what the facility doing actually working? And a lot of programs, I would say most programs are going to publish their outcomes on their website, where you will see firsthand if they've seen a significant reduction in symptoms and a significant increase in overall functional well-being. But if you don't see those outcomes, I would ask, what do your outcomes look like? Can you send me a copy of your outcomes? Or if their outcomes aren't on the website, hey, I don't see outcomes on your website. And you could pose a question about, do they have outcomes? So again, we want to know, is what this facility is doing effective? Because if it's not, then we know this isn't the facility. But again, if it is, then we can be sure, okay, this is the symptom reduction. This is an overall increase in functional well-being. From a clinical standpoint, again, they're going to get individual therapy. They're going to be paired with an individual therapist. It's usually one time a week, sometimes twice a week. That is individual therapy on top of family therapy. So, family therapy is going to be at least once a week, usually virtual, if you're in the area in person as well. Now, family therapy is required at most facilities. I know for Embark, it is required for us. We need 100% buy-in from parents. We need 100% commitment from parents. We say that because this is a family systems issue. And I say that because if you have a child who is dysregulated and you're walking on eggshells around that child, and if you know, everyone else has become some form of dysregulated, right? If you're walking on eggshells around that client or around that child, everyone else is forming some sort of, they have their own things going on. And so it's a family systems issue. And we want to make sure we are really working with the family as a whole, because we can't just have the identified client and then the child come back in the environment. It doesn't work that way, right? So we need 100% buy-in from the family. We don't need 100% buy-in from the kiddo. We need about 50%. We need them to know they're not going to summer camp, that they're going to residential care, and that it's going to be hard work, and we're here to help you with that. But we do need 100% buy-in from the family because it is a family systems approach. When the child is with us, we are going to be doing family therapy and parent coaching when the client becomes, the kiddo becomes dysregulated, how you can keep your place regulated, how you can stay regulated when your child becomes dysregulated, how your lid doesn't become flipped when your child's lid is flipped, how you can maintain consistent boundaries with them, how you can maintain your just inner peace when you're around them. So again, it's a family systems approach. Group therapy as well. So we do a lot of group therapy. I get questions from parents a lot of times that are that ask me, okay, so I'm a little curious about this group therapy piece. Like, what if my child picks up an unhealthy behavior? Well, your child is going to pick up unhealthy behaviors because that's just what happens, right? They are malleable. Our kids pick up unhealthy behaviors all the time. Now, what I will say is if they pick up an unhealthy behavior in residential, such as, let's say, self harm, right? You're like, hey, my kid was not self harming before they came. Now they're self harming because they saw another kid self harming. If they start self harming in residential, to be quite honest, we can work on that. That actually is something that we look at and say, is there something we're working on in therapy that's really, really, really hard for you to work through, to where you've decided an unhealthy coping skill is going to get you through? Because we can work on that. We can behavioral chain that and say, there's a reason why you've picked up this unhealthy behavior. It's unhealthy. So walk me through why you think this is a better alternative than working through maybe the trauma that you're trying to work through right now. So in theory, it's scary, right? We don't want our kids to self-harm. The additional piece of that is if they're with us, that's something we can work on. That's when the hard stuff comes into play. So kids are going to pick up behaviors. I have a 3-year-old, right? And he picks up behaviors all the time at daycare. And as a parent, I just got to work through it with him. Hey, we don't say that. Hey, we don't hit. Hey, we don't do this. And that's just what we do as parents, right? Our kids are going to pick up behaviors because they're malleable in that way. The last piece of it is experiential therapy. When talk therapy isn't enough, right? They're kids. At the end of the day, they're kids. And so we're going to take them outside. We're going to take them, whitewater rafting, equine assisted therapy. We do a lot of animal assisted therapy. So I have a dog. He's actually sitting over here with me. We do a lot of animal assisted therapy with horses, with dogs. We have goats at different locations, whatever it might be. But we get the kids out to do things with their senses, get more sensory focused, not so much here with our phones, right? We want to do things that engage all of our senses. So talk therapy is wonderful, but it doesn't work for a lot of our kids at all the times, right? Sometimes they're just talked out. And so we need to get them out. We need to get them in this place of engaging all of their senses. And so that's where that experiential therapy comes into play at a lot of our places. Art therapy is a great alternative to that as well. Just engaging what's going on up there, what's going on in your heart, what's going on in your mind. So clinical. So we looked at safety, we looked at clinical. Now we're going to look at education. So again, I'm going to pull all of these up for you so you have them. Again, this is our Whitehaven location. This is like the dining room area. For most residential centers that serve teens, they are going to keep the education component. I know that's so important. We don't want kids to fall behind. And I've seen when parents have taken kids out of school, and I'm not saying there's anything wrong with it. I just haven't seen it go super well. So one of the things that we do at Embark specifically, and one of the things I've seen at a lot of other centers is they have a fully accredited school on site. For us, we use a place called Mountain View Academy. We've always used them at all of ours. We have 36 locations across the country, and we use them for all of our locations. We want to keep kids in school. If there's AP courses, we want to keep kids in AP courses as well. We know, again, that's a big part. The teachers work directly with the client school to keep their coursework on track. So on admission day, usually we say if they have books or Chromebooks or iPads, bring them with them so that they can work with that. And it's filtered into their daily schedule. This isn't an added thing. This isn't hey, after dinner, you're going to do schoolwork. No. This is in their daily schedule, in their daily curriculum, because at the end of the day, they're going to go back to school, right? Some way, shape, or form, they're going to go back to school when they go home. So it can't be foreign to them. Okay. We have to keep them kind of engaged in some sort of their curriculum of what they're used to so that when they go back, it is not a complete and utter, they're not completely surprised, right? And we're keeping them on a good daily schedule as well. So when they go back home, they're with you and you have that daily schedule intact. I want to also say cell phone use, specifically for us, is restricted to minimize distractions. In our residential centers, our kids do not have their cell phones. And I know for some people that can be really triggering and that can be really beneficial. Um, I think for us, they do have access. They'll have access to phones to talk to you. So don't think you're not going to talk to them for 90 days. You will see them. You will talk with them. We have parent seminars. We have family weekends. They'll have visiting passes. You'll be able to talk to them on the phone. The cell phone piece is just because a lot of our kids, social media has become a big precursor to a lot of their mental health issues. I'm not saying it everyone. I don't want to generalize it. We do want to minimize the cell phone use and the social media use, but we also want to be able to reintroduce it in a healthy manner. So we may take it away, but we're going to reintroduce it in a healthy manner because again, what a lot of our kids, what we've seen, especially with this generation, it's hard, is they're growing up in the technological world. We're trying to figure it out together. And so being able to reintroduce it in a healthy manner, but we are going to minimize that cell phone use for them. Okay, so we went through safety, we went through clinical, we went through education. Now you say, okay, I'm here. I've been recommended residential. What does it look like? I'm going to walk you through this process. The process can be daunting. I'm just going to tell you, there's a lot of logistics that can happen. But I want to just kind of give you an overview. So let's say Dr. Seltzer recommends residential for you, for your child. And you have my cell and you call me. So you say, hey, I'm such and such. I was recommended by Francine from MPG. Oh, wonderful. I'm so glad that we connected. What I'm going to say is tell me a little bit about what's going on. Just give me a brief overview. What's going on with your kiddo? Okay. We're going to go through that, just that brief overview. Then I'm going to tell you a little bit about, okay, how much do you know? For me, this is just how I do things. How much do you know about Embark? Do you want me to give you kind of just a brief overview of what we do? And maybe you say yes or no, or I just have a couple questions. And then I say, okay, this is how we kind of walk through the process. First up, are you going to be utilizing private insurance? Now, I know a lot of times if that's the first question, we're like, oh my gosh, we already got into the money piece. We just do that because one, I want to know if it's going to be financially in your wheelhouse for you. That's just it. That's all. Again, I'm going to tell you, I'm fully vulnerable and transparent with the process. So, if it's not a great fit for you, it's not a great fit for you. It's fine. Okay, we'll work through it. So first off, if you say, yes, I would like to utilize my private insurance, a lot of times what I'll do is say, hey, if you feel comfortable, text me a front and back of your insurance card, or you could email it to me, whatever. I delete it off of my phone because I don't want that information on my phone, but I want to make it easy for you. What we do is we go through the verification of benefits process. So that we run it through a digitized system. It's no cost to you. So it's kind of like a credit check. A lot of times, it's no cost to you. We just run it through the verification of benefits process, which is through we have a system we use called Symmetry. From that, it will pull our verification of benefits. Now, the information that it pulls is this. Now, this is tricky if you're not familiar with the insurance process. There's a lot of words I'm going to say. So again, I will give this information to you. It'll pull out your deductible, it'll pull out your coinsurance, and it'll pull out your out-of-pocket maximum. So I'm going to give you a couple of numbers. I'm going to give you a couple of numbers just as an example. So you give me your insurance and you have Blue Cross Blue Shield. And so we run it through and basically we look to see, is it an in-network provider? Meaning, do we have a contract with Anthem Blue Cross Blue Shield? A contract meaning we have a contracted rate with them. We're a preferred provider. Or is it an out-of-network? Is in that meaning, oh, sorry, that meaning that we don't have a contract with them, that it would be utilizing your out of network benefits. So for the grace of this moment and this time, we're going to go with in network because that's typically easiest. So we see it's in network. From there, we look at your deductible. Let's say you have a really great plan. You have a $500 deductible. And so we see, okay, your deductible is $500. How much of your deductible have you met? And let's say you've met $500 of it. You've met your deductible. We're like, okay, great. So you've met your deductible at $500, meaning that insurance will kick in at a percentage of the contracted daily rate, and you'll be responsible for a specific percentage of the daily rate. So let's say your deductible is $500, you've met $500. Therefore, Anthem will start to pay the average daily rate at 80% of the average daily rate, and you'll be responsible for 20% of that average daily rate, right? So let's say our daily rate's $1,500. Anthem will pay 80% of that $1,500. You'd be responsible for that 20% of the $1,500 until your out-of-pocket maximum is met. Your out-of-pocket maximum, let's say it's a great plan, it's $1,000. Perfect. Then after your out-of-pocket maximum is met, insurance will cover it 100%. Okay, so let me walk you through that again. So we look at insurance in network or out of network. Let's say we're in network. We look at your deductible. What is your deductible? $500. Great. How much have you met? Oh, you've met 500. Great. So insurance is going to kick in at 80% of the daily contracted rate. You will be responsible for 20% of that daily contracted rate until your out-of-pocket maximum has been met, which let's say is $1,000. Then insurance will pay at 100%. So what you'll get while your child is in residential, you'll get what's called EOBs, explanation of benefits. And as we know, when we go to the doctor and we get an explanation of benefits, they have the asterisk saying, this is not a bill. You'll get those, right? You'll get an EOB that says this is not a bill. That's just what we're billing your insurance. And you'll see that coinsurance in there, that percentage, that 80%, that 20%, the deductible, the out of pocket, you'll see the accumulations there as well. So again, when you hear that, if you're utilizing private insurance, that's just kind of what we kind of go by. That's the VOB, that's the verification of benefits. So we say that to you, and then you say, okay, yes, I can do that. That seems doable. Perfect. Then we go through the intake assessment. And typically, the intake assessment is about 45 minutes to an hour over the phone. We don't have to have you in person, just over the phone. And that gives us a full clinical picture of what's going on with your child. So we go through education, we go through psychosocial, we go through developmental, we go through presenting problem. Have they been to any other providers? Have they been in the hospital? Where have they been? All of those different things. And we go through all of those with you for about 45 minutes. Then we send that off to our clinical reviewers for clinical recommendation, and they give us the green light and let us know, hey, they're great for our program or not so great. And then we go from there. We give you a length of stay, which is usually about 90 days. And you say, great. And then we do a pre-authorization of services. The pre-authorization of services is basically to say, before you step foot on our grounds, that that insurance has approved that they can come to our facility, and that you are not responsible for them, that insurance will pay a certain number of days. And then we'll do an admission confirmation. Okay. So we do that pre-auth first. Sometimes we have to wait on it a little bit, but I will tell you, once that pre-auth is done, typically it's like the next day. So it's a pretty quick turnaround, right? So I had someone who their pre-authorization was approved yesterday. They're admitting today. We can't say, hey, we got to wait until Friday, or, because insurance can say, well, then they can stay home then. And then they resend the authorization. It's a tricky process. So a lot of times we got to go quick. And then admission confirmation. Now, breathe with me. The most difficult day as a parent will be admission day. 100%. It is going to be a lot of overwhelm. You're going to meet with a lot of people, and you're leaving your child at a residential care center for 90 days. It's hard. I have experienced it on a number of occasions with families. There is a moment of grief. There's also a moment of relief as well. I've had many, many parents call me on their way home. I've called them and said, how did it go? How are you feeling? A lot of parents say relief. I had one parent who her child was homicidal towards her. She said, this was the first time I took a shower and didn't lock my door. But I will tell you, it's going to be difficult, and that's okay. But you have support around you. You can leave your child there knowing that they're safe. You're going to meet with everyone on the team. You're going to have questions that you're going to ask. You're going to have so much support, but it will be the most difficult day. You never thought you'd have to do this, right? You're dropping your child off at college. You're not dropping your child off at residential care. But know that you have support. Know that this is what you're doing, right? As a parent, it's what you got to do. But now you're scared. Now you're scared. You've driven away. Child calls you that night. I want to go home. Or your child calls you weeks on end. I want to go home, mom. I want to go home, dad. I want to go home. And you're like, let me tell you, I'm mom. I'm with you. It's hard. They are telling you they want you to pick them up. Should you pick them up? No. The short answer is no. Because let me tell you, unless you know that there is something unsafe going on at that treatment facility, and you've done the research, if something has or hasn't happened, 9 times out of 10, it's because they're going through something really hard right now, and they want to go home because they want to avoid. They want to go home because it's hard. But you can't pick them up. Don't pick them up. Okay? You're going to have support. You're going to have support from your own team. You're going to have support from the team of professionals. You'll know. Let me tell you, you'll know if it's a safety issue and you have to pick them up. You'll know. There'll be multiple instances where you'll know. But if your child is calling you and crying and say, I want to go home, I can't do this anymore, that's when you know they're really working on something really, really, really hard, and they need to be there, because that is the nitty gritty of what's going on. That's the nitty gritty of where they're getting to the function of the behavior, of the why. So just breathe with me, because it's going to happen. It will. And it's going to be so hard, and you're just going to have to breathe through it, and you're going to have to just trust in the process. Okay. So myths, because I'm going to go from there to here. The first myth and misconception: I can manage my child at home. The short answer is no, you can't. And if you could, residential would not have been a recommendation. Now, there is an article, and I'll send this out to Madison. I was actually reading about it yesterday. We know there's no secret. We have a mental health crisis in our country and our world. We do. We have a shortage of residential care centers for our kids. We do. We really do. And it's becoming more apparent as more places are closing. But my friends, you cannot manage your child at home. You have jobs, you have lives. You can't keep your child 100% safe. You got to sleep too. And as I said, crises don't happen in the middle of the day, they happen at night, right? And so when residential becomes the recommendation, you just have to trust and just let it happen. Right. And get yourself the support that you need. You have support from residential, but you have to get additional support for yourself. And I'm here to help with that as well as a fellow parent. But you can't manage your child at home and that time. You just can't. The next misconception, oh, the F word, fail. How many times as a parent have you said, I failed? My son is 3, and I can't even count how many times I have said to myself, have I failed as a parent? Friends, residential does not mean you failed as a parent. It doesn't. It does not. It means that whatever your family is going through at this time is bigger than you. Something you never thought you'd experience any time in your life. It just is. And as parents, one of the things that we talk about and we say, I just want my child to be happy. Right? As parents, we're just like, that's all I want for my child is for them to be happy. But let me tell you, happiness is fleeting. We know it. My son is 3. My son is in love with chocolate milk. He loves his chocolate milk. And if I don't have his chocolate milk in a sippy cup when he wakes up in the mornings, he's sad. But if I bring it up to him, he's happy, right? It's fleeting, sad, happy. We're like in this like little this fun little conflict resolution, right? But joy. I want you to think about joy. Because this is what I think about when I think of residential means I failed as a parent. Joy is resiliency. Joy is enduring. At Embark, we say we want to create joy and heal generations. I want to create joy in your family. And residential may mean you've overcome something so difficult as a family that you come out on the other side with this deep, enduring sense of joy and gratitude in your heart. It does not mean you failed as a parent. It all honestly means you are stronger as a family because you have overcome together. So residential does not mean you failed as a parent. It means your trajectory looks a little bit different than your neighbors. And that is totally okay. And you have more tools and skills than a lot of people swimming in the same boat as you. So when you feel that, know that there's resiliency in saying, I have to call on help. I have to provide, I have to have this support. And the last piece of it, because again, the elephant in the room, I've watched the documentaries, I've watched them too. Hell Camp, the program, seen the reviews. Why would I send someone to residential? Why would I send my child to residential that would hurt them? And I will say this, amen to those programs that got shut down because that's what needed to happen. That's absolutely what needed to happen. The thing that is really difficult is there's a generalization now that every program is like that. And that's not the case. You know now the questions to ask. You know the feeling that you feel when you talk to an admission counselor. If you feel that warmth, if you feel like I can send my child there, you know it. You read the reviews. I read the reviews. I'm an Amazon shopper. Okay. I read every single review. I also know that if there's every 5-star review, I know something's up. Is somebody fabricating these reviews? I also know the population I'm dealing with too. So I want you to be able to do your research, but I also want you to know, yes, amen to those programs that are getting closed, that are getting shut down, because yes, they needed to be, because yes, there were a lot of difficult things going on there and kids were getting harmed. But I want you to also know that it's becoming more generalized and not every program is like that. And we do have a residential care shortage. So you have me, and part of my job is to go to residential centers. I'm a mom, so I am not going to send anyone anywhere that I would not send my own child. And I can put my name next to that. So you have me, you have the staff at MPG. I have friends and colleagues that I can call on if I don't know the facility. You can call me, text me at any time, ask me questions. I'm happy to be a transparent, open book because, again, 100% I am a parent. So I am not going to send you somewhere I wouldn't send my child. So I'm going to go with this. Any questions? But before I do that, I want to put my contact information up here because I want you to have it. And I say that wholeheartedly. Text me, call me. This is my personal cell. I've had this cell since I was 16. It's not going anywhere as far as I know. You can call me, you can text me, you can email me. Just tell me who you are and say, I just have a question about residential, or I have a question about this facility, or what do I do if I'm looking at residential, whatever it might be. I want to be a resource to you. Most importantly, I'm a parent just like you are. So know that I'm going to be vulnerable with you. I'm going to be transparent with you, and know that I would not steer you anywhere that I would not go. So I'm going to open it up for questions. I know there might have been some that came through the chat. So yeah, I'll keep that up for just a minute so you can get my info, and then Madison will have it as well.
Perfect, thank you. So if you have a question, now would be a great time to post it in the Q&A, or if it's something you would rather ask verbally, you can raise your hand. There's a button that should be at the bottom of your screen, and we can unmute you so you can ask. If you think of any questions after we end the webinar today, just feel free to email professionaldevelopment@manhattanpsychologygroup.com, and we can connect you with Ashley, or you can email her directly at the email that's on the screen, or text her on the cell phone that you see here. Ashley, if we do get any that come in after, I will be sure to send it your way. I don't see any questions coming in, so I think this is the conclusion of today's presentation. Thank you so, so much. I think this is a much needed topic for our community and for any of the parents that would need some of this extra support. So thank you so much, and thank you everyone for attending today's webinar. Again, if you have any questions, please reach out.
Thank you so much. Thank you all for hopping on today. And thank you to Manhattan Psychology Group for putting this on. Again, if you need anything, please, please, please feel free to reach out.
All right. I hope everybody has a great day.
Thank you.
Bye.